Hi, my name is Denise Freire and I'm going to talk about antithrombotic therapy after acute coronary syndrome or PCI in atrial fibrillation. Definition: antithrombotic therapy is a fundamental treatment to prevent thrombotic complications and death in various cardiovascular disorders. Acute coronary syndrome is the result of an obstruction of a coronary artery, while PCI, percutaneous coronary intervention in atrial fibrillation, is a procedure used to restore blood supply to the heart. Both cases are associated with the need for antithrombotic therapy.
Well, it's been an interesting time in the last 2 years in patients who have atrial fibrillation who need to go under PCI in getting new data to help address what should be the antithrombotic mix. And following the WOOS trial, we have done studies where we dare to stop aspirin, and that looks like it's a smart answer. The concept is that using triple therapy with aspirin, a P2Y12 inhibitor, and an anticoagulant is needed for the atrial fibrillation and the stent, and yet it leads to a lot of bleeding. And so the idea is, could you take away the aspirin and have less bleeding and still get away with that from a thrombotic point of view? And the answer seems to be yes, so that WOOST and Pioneer AF and then Redual PCI all found less bleeding when you take away aspirin, and so have dual therapy with a P2Y12 inhibitor and, in the latter cases, a novel oral anticoagulant. Fortunately, the thrombotic events don't seem to be increased even when taking away aspirin. So you use aspirin obviously before PCI in the hospital, but then at discharge stop it. And we saw in Redual PCI like 30 to 50% lower risk of major bleeding and similar rates of thrombotic events. We studied dabigatran in Redual PCI, and the approved dose of 150 milligrams had just identical rates of stent thrombosis, MI, etc. So full dose anticoagulation, P2Y12 inhibitor, usually clopidogrel, although we had some ticagrelor, but then no aspirin, and the outcomes were really terrific. And so a recent North American consensus statement, I was a part of it, about 15 of us, did note that with now 3 trials showing this, that this could be sort of the default strategy, that after or at the time of discharge that you'd send people home on the dual therapy and allow risk stratification. If you had a high thrombotic risk, a left main stent or something, you think maybe a month or more of triple therapy, but to really shift towards this dual therapy as the default. And so we'll see how that plays out. There are some new trials coming, but that does seem to be a nice advantage that we can offer to patients and really reduce bleeding for them.
Applications in medicine. In an international trial, patients with atrial fibrillation who had an acute coronary syndrome or had undergone PCI received a P2Y12 inhibitor, clopidogrel, and a apixaban or vitamin K antagonist or aspirin or matching placebo for 6 months. The primary outcome was no major bleeding. Secondary outcomes include death, hospitalization, or ischemic event, stroke, myocardial infarction. Patients in the apixaban group had a lower incidence of death or hospitalization than those in the vitamin K antagonist group. The result of trial concurs with a North American trial in which it is recommended new oral anticoagulant plus a P2Y12 inhibitor. So the result supports the use of a regimen of apixaban with a P2Y12 inhibitor, most commonly clopidogrel, without aspirin in a broad population of patients with atrial fibrillation and recent acute coronary syndrome or PCI.
Triple antithrombotic therapy is the standard of care for patients with atrial fibrillation undergoing percutaneous coronary intervention, or PCI, with stenting. Oral anticoagulation and dual antiplatelet therapy with a P2Y12 inhibitor plus aspirin are used to prevent thromboembolic events, including stroke, systemic emboli, and stent thromboses, but they are associated with a high risk of major bleeding. A potential therapeutic strategy to reduce thromboembolic events and bleeding risk is dual therapy, with the oral direct thrombin inhibitor dabigatran and a P2Y12 inhibitor without aspirin. In the multicenter randomized redual PCI trial, 2,725 patients with non-valvular atrial fibrillation who had undergone PCI with stent implantation within the previous 120 hours were randomized to receive either triple therapy with warfarin, a P2Y12 inhibitor, either clopidogrel or ticagrelor, and aspirin for 1 to 3 months, or dual therapy with dabigatran, 110 or 150 milligrams twice daily, and a P2Y12 inhibitor. The primary endpoint was time to first major or clinically relevant non-major bleeding within 14 months. The rate of major or clinically relevant non-major bleeding was 15.4% in patients receiving 110 milligram dabigatran dual therapy, as compared with 26.9% in patients receiving warfarin triple therapy. Similarly, the rate of major or clinically relevant non-major bleeding was significantly lower in patients receiving 150 milligram dabigatran dual therapy than in those receiving warfarin triple therapy. In the secondary endpoints, there was no significant difference in the rate of thromboembolic events or death between patients receiving 110 or 150 milligram dabigatran dual therapy and those receiving warfarin triple therapy. The authors conclude that in patients with atrial fibrillation after PCI, dual therapy dabigatran and a P2Y12 inhibitor significantly reduced the risk of bleeding as compared with warfarin triple therapy, with no increase in thrombotic complications. Available at NEJ.
Pros and cons. Pros. It has been proven that dual antithrombotic therapy reduces the incidence of recurrent ischemic events and stent thrombosis. Cons. Are less effective in reducing the incidence of cardioembolic stroke associated with atrial fibrillation.
Among the many late breakers that were shown at ACC, one trial was called Gemini ACS. Gemini was focused on what is the optimal antithrombotic strategy after an ACS. For many years, we've used dual antiplatelet therapy combining a P2Y12 inhibitor and aspirin. Aspirin, we know, is a cheap agent. It has substantial efficacy, but it's also an agent that creates bleeding, particularly GI bleeding. On the other hand, we have theoretical and clinical evidence that combining antiplatelet therapy and low-dose anticoagulation might be extremely beneficial. Specifically, in the Atlas ACS trial program, combining rivaroxaban with dual antiplatelet therapy of clopidogrel and aspirin was associated with a substantial mortality reduction, close to 40% mortality reduction, something that's really very impressive. The problem is that there was a price to pay for this efficacy, which was a very substantial increase in bleeding as well. And so Gemini tried to address the question of, can we drop aspirin and replace aspirin with very low dose anticoagulation using a factor Xa inhibitor such as rivaroxaban and get the best of both worlds? Maintain the efficacy, if not increase the efficacy and lower mortality, and do this at an acceptable rate of bleeding. So we designed Gemini ACS as a stepping stone to a large phase 3 trial, which I believe should be a mortality trial. This is a phase 2 trial looking at the feasibility and the safety of this approach, and the primary outcome was bleeding, TIMI significant, clinically significant bleeding, to have some sensitivity and power. And the trial randomized approximately 3,000 patients receiving a P2Y12 inhibitor, either ticagrelor or clopidogrel, to being randomized to low-dose aspirin or low-dose rivaroxaban. The bottom line is there was no difference, statistically significant difference in bleeding between the two arms. overall as well as across the two strata receiving ticagrelor and clopidogrel. There was no difference either in an exploratory composite ischemic endpoint trying to seek out whether efficacy was maintained, but the trial was underpowered for this, and I think these conclusions have to be viewed as very exploratory. So I think this is exciting because it shows that for the first time in 30 years, we have an antithrombotic strategy that is safe and does not incorporate aspirin and has the potential to be tested in a large phase 3 trial to see whether we can further reduce cardiovascular mortality post-ACS. I think there's a promise here that deserves to be explored in a large phase 3 outcomes trial.
ACE2 applied in Ecuador. In Ecuador, the use of a direct inhibitor plus a P2Y12 receptor inhibitor without aspirin is considered the most appropriate strategy for a patient with atrial fibrillation, and vitamin K antagonists combined with an antiplatelet agent are avoided to avoid bleeding.
I've been involved in antithrombotic therapy for more than half a century, and I've watched the evolution of anticoagulant therapy from the old standard of heparin and warfarin, and I think that the first major breakthrough was the introduction of low molecular weight heparin in the 1980s. This truly changed the way that we manage patients with thrombosis, both acute treatment and also prevention of thrombosis. Subsequently, we developed drugs that target single coagulation factors, and the prototype of that was fondaparinux. I had the pleasure of being involved in the early work with both of these agents, both low molecular heparin and fondaparinux, and they still remain one of the principal ways of treating patients acutely by parenteral administration of anticoagulants. Towards the end of the last century, there was a very important development in antithrombotic therapy. It was based on a much better understanding of coagulation. It was possible to target single coagulation factors. The two main targets are factor 10 and thrombin, both key in the coagulation cascade, and it was possible to synthesize drugs that target both factor 10 and thrombin to inhibit coagulation. Factor 10 is a key coagulation factor, and it's not a surprise that much of the development was targeting activated factor 10, and there are now 4 factor 10 drugs available worldwide: rivaroxaban, apixaban, edoxaban, and betrixaban. The thrombin inhibitor, dabigatran, is also available. This is an effective agent, but the development of thrombin inhibitors was set back by a drug called zymalagatran, an effective anticoagulant thrombin inhibitor, but was associated with hepatic toxicity. And there's a concern that this might be a class effect of thrombin inhibition. As it turns out, that's not the case, and dabigatran is effective and does not have that problem. But I had the pleasure of being involved with the early development of these drugs clinically, and did some of the first dose-finding studies and subsequently the phase 3 trials, particularly with rivaroxaban, demonstrating its effectiveness both in prevention of thrombosis, treatment of thrombosis, and a reduction of stroke and atrial fibrillation. These drugs, in my view, will completely revolutionize the management of patients who require long-term anticoagulation. They are orally active, they do not require anticoagulant monitoring, and have been shown to be effective, and in many cases reduce the risk of major bleeding complications, and in particular reduce the risk of intracranial hemorrhage. So in my view, in this decade, the DOAC drugs is what we're calling them now, direct oral anticoagulants, will be the drug of choice for patients who require long-term anticoagulation.
Conclusion. In patients with atrial fibrillation and a recent acute coronary syndrome or PCI treated with a P2Y12 inhibitor and antithrombotic regimen that include apixaban without aspirin resulted in less bleeding and fewer hospitalizations with a significant difference in the incidence of ischemic events than regimens that include a vitamin K antagonist, aspirin, or both.
So patients with atrial fibrillation have an increased risk of cardiac thromboembolism and need oral anticoagulation to manage that risk. But we have a challenge when a patient's had an acute coronary syndrome or needs percutaneous coronary intervention, because in those patients there's clear evidence base for dual antiplatelet therapy with aspirin and a PCI inhibitor. And so there's an indication on the one hand for an oral anticoagulant and on the other hand for dual antiplatelet therapy. And so what we've tended to do is combine the treatments into triple therapy. But the challenge here is that we know that incurs a high bleeding risk when we combine triple therapy. And what has been the gap in the evidence is knowing whether we can cut back, just use two agents to manage thrombotic risk, both the risk of cardiac thromboembolism and the risk of stent thrombosis or further coronary thrombosis. And so this is the real challenge that has led to a lot of uncertainty in the community as to what the best regimen of antithrombotic therapy is for which particular patient. There have been many large studies that have looked at the role of non-vitamin K antagonist oral anticoagulants. We've got a number of agents now, apixaban, rivaroxaban, dabigatran, edoxaban, and these agents have all in their large phase 3 trials shown superior safety compared to vitamin K antagonists, predominantly warfarin. And particularly there's a lower risk of intracranial hemorrhage with the NOACs compared to the vitamin K antagonists. And this has led to increasing adoption of these new agents, which have some advantages also in terms of not needing regular monitoring of coagulation in order to set a dose. The doses are determined according to renal function and other clinical characteristics. But most patients, the majority of AF patients, requiring a single dose of these NOACs in order to achieve superiority compared to agents such as warfarin.